Okay, so welcome back to another episode of the Expert Insight series, where we interview worldwide expert spine surgeons who kindly share their professional and personal experiences with us. I am Maria Antonietta Scazzariello, orthopedics and traumatology resident from Milan, Italy.
And I am Victor Martín Orgojo. I'm an orthopedic and traumatology resident from Valencia, Spain, and we are both members of the new AO Spine Youth Club.
In today's interview, we are honored to welcome Professor Claudio Lamartina. He is currently the co-chairman of G-Spine 4 Division at Ospedale Galeazzi Sant'Ambrogio in Milan, Italy. With a career marked by excellence, Professor Lamartina is a leader in spine surgery.
In his path to become a renowned spine surgeon, he first specialized in anesthesiology and later on in orthopedics and traumatology at the University of Milan. He is the former chairman of the Regional Board for Europe and Southern Africa at the AO Spine. He is also a professor of orthopedics at the University of Milan and a professor of neurosurgery at the University of Turin. He is the deputy editor for clinical science of the prestigious journal European Spine Journal.
With a surgical experience of over 3,000 complex spinal procedures, Professor Lamartina has become a world authority in advanced techniques in minimally invasive spine surgery and adult spinal deformity. In fact, he is constantly being invited as a guest surgeon in countries like Libya, Jordania, and Kuwait.
So we are very honored to have Professor Claudio Lamartina here with us. So thank you so much, Professor, for joining us. It's a pleasure.
It's a true honor.
Thank you very much for your very kind introduction. Thank you.
Thank you.
Okay, so let's start our interview. Before we begin, could you tell us your full name, specialty, and full current position?
My name is Claudio Lamartina. I'm orthopedic spine surgeon in Ospedale Galeazzi Sant'Ambrogio in Milano. I'm co-chair of G-Spine 4 spine surgery department in this hospital.
Thank you. So the first question, could you share a bit about your roots and your hometown? How was it?
I was born in Marsala. Marsala is a little town in Sicily, actually in the far west of Sicily. But I spent only my first 5 years in Marsala. Then my family moved to Palermo.
Mm-hmm.
I was in Palermo until 24. When I achieved my degree in medicine. After this, I moved to Milano.
Mm-hmm.
I'm in Milano since 1975. That means a long time in Milano.
Super.
Actually, I don't know exactly if I'm a Sicilian or I'm from Milano. Maybe it's a sort of a combination of both. My roots are in the south and in the north of Italy.
Uh-huh.
Okay, so from what you said, we get that you undergo your training. You underwent your training in Milan and you completed your residency also there. How was the experience in Milan?
I had a very good experience in Milano because I start my career in Galeazzi.
Mm-hmm.
I'm until now in Galeazzi. That means I spend all my career in the same institution. It is obviously unusual, but actually this is the reality. I had the great opportunity to be formed by my first mentor, the founder of the Galeazzi, Professor Ernesto Zerbi, that gave me the very important first knowledge about orthopedics.
Super. And before becoming a spine surgeon, what did you do? What are the initial steps before becoming a spine surgeon? Because we read you also have the specialty of anesthesiology.
Okay.
And we found this very interesting, no? So could you tell us a bit more about this?
But actually, I had a very limited experience in anesthesia.
Anesthesia.
Because I spent just a few, my first 3 years of career in this specialty. That means in one hand I have 3 years, in the other more than 40. That means actually I forgot all about anesthesiology.
So you consider yourself a spine surgeon, obviously.
There is no discussion. Even if I spent the first 8 years in trauma, my first 3 years, 8 years was in trauma.
In general trauma.
No, in general trauma, in orthopedic trauma.
In orthopedic trauma. Super.
This is my first knowledge about mechanics, about synthesis was in long bone in trauma.
Super. Anto?
Okay, so, and if you were to give an advice to younger surgeon, why would you recommend spine surgery? And what do you think are the pros and cons about becoming a spine surgeon?
The pro mainly is the fact that spine surgery is a very challenging surgery. Is a very young surgery. That means there are a lot of opportunities to well define, let me say, discover in this field. It's not like hip surgery, in which we have a significant solid base in hip surgery. In spine is everything should be better defined. We are just at the beginning of this surgery. This is a huge opportunity for me, but also for the young generation.
So you think people
my opinion, important point, the pro. The contrary is the fact is necessary to spend a lot of time in learning curve. That means you have to spend years and years for having a good idea about this kind of very often complex surgery.
Yeah.
This is what you should to put in the table when you have to decide for this kind of career. If you want to become a spine surgery, you have to pay attention about this. There are a lot of opportunities. In the same time, you have to accept years and years of learning curve.
Learning curve. That's definitely true. And in this sense, Professore, what do you think are the personal traits that a spine surgeon should have to become a good, well-rounded surgeon? What are the qualities that we need to acquire or that we have to have?
I do believe in this. I believe that you must be strict. This
strict.
is important. Strict. That means you don't have to invent anything. You have to follow what we know until now. But in the same time, you must be flexible. This is in part a sort of contradiction. Let me give you an example. When you operate a complex spine case, you have to have every time a plane B or C. It means sometimes it's impossible to achieve the target number one. You must have the flexibility for realizing this during the operation. You have to change a little bit just in order to give the best result to your patient. This is very important. In one side, you must be strict. In the other side, you must be flexible. I think this is the most important trait that a spine surgeon could have.
Yes, that's a very interesting insight. Yeah. And if you think about your professional life, is there someone who inspired you the most to become the surgeon you are today, and why?
I had at the beginning a basic formation, a basic, yeah, coming from Ernesto Zerbi. Ernesto Zerbi was a hip surgeon. He was a trauma surgeon. 4 years, my first years in orthopedics was in this direction. This creates a sort of solid scientific base for treating the spine, because the rules of osteosynthesis in long bone or in short bone is the same that you have to apply in spine. For this, obviously, Ernesto Zerbi was very important for me. But after this, I have to mention Pierre Stagnara in Lyon. Pierre Stagnara was a giant in spine surgery, in deformity especially. Let me give you an example. Pierre Stagnara in the early 18th of last years, obviously, of last century, understood very well that you cannot have an average of lumbar lordosis or thoracic kyphosis. At that time, he realized that there are different spine, different normal spine, different normal subject in which for instance, the thoracic kyphosis ranges from 20 to 60, and more or less the same for lumbar spine. This was my first time. He was very clear in teaching this. This for me was the first time in which I start to understand about sagittal alignment.
With Stagnara.
Yeah, ante litteram, he defined the sagittal alignment. Later, Duval-Vauper defined how to measure the pelvis. Roussoli, a few years later, defined what important is the relationship between pelvic parameters and lumbar spine. But the first surgeon that clarify there is no a main normal value of lumbar spine lordosis was Pierre Stagnara.
Wow.
Then I had the huge opportunity to spend time in Paris with Roi Camille. As you know, Roi Camille was the surgeon that introduced in the daily practice the pedicle screw. You can understand how important it was for me this kind of knowledge. At that time, it was really a revolution. Finally, I have to mention Max Sebi. Max Sebi is a very important person in my career, because he helped me dramatically.
In which way?
Every time. He gave me the huge opportunity to be part of his team. When he was in Montreal, in McGill University, he gave me this opportunity. This was the way for introducing in Eospine, because he was he created together with John Webb Eospine. I was with him just at that time. I had a lot of opportunity to follow him just at the beginning of this huge adventure.
Super. Thank you so much for telling us all of your personal experience. In this sense, you have talked about the AO spine, and how important do you think it is for a spine surgeon to be part of a community, an academic community like AO spine? And in which way did AO spine influence your career, Professor Lamartina?
AO spine first, no, at the beginning I was in trauma, in our trauma.
In our trauma.
In our
Okay.
trauma. When Max Eby created AO spine, I moved to our spine.
Uh-huh.
This was my history. But the point is, AO is very important for a lot of reasons. First, because following AO principle, you
Mm-hmm.
you can understand why you have to be strict. You cannot invent every day a different theories or a different surgical technique, because very often the most important efficient surgical technique are well described in AO.
In AO.
This is the first point. But in the same time, you have the huge chance to be part of the very international communities in which you can be at the same level, is a peer community.
Uh-huh.
You can speak with Max Eby, the founder of our spine, or with me, or with Pedro, the current chairman in Europe, or with Luis Viale in South America. You can speak as peer.
Yes.
This is a very important source of knowledge. Very often you have the chance to create a very strong and solid friendship.
Uh-huh.
This is the other very important point. This is the reason why I do believe that the AO, in general speaking, the AO spine are the most important step in your career, or in my career, for this huge opportunity. Very often you are inside a very clever or intelligent community. In this way, you can learn a lot.
Exactly. And this is actually what I think Manto and I are enjoying a lot about this new group that we are like building up, is the possibility of communicating and making friends all over the world, having the opportunity the chance to speak with you. So I think it's as you say, it's a great opportunity for this reason, no? Apart from all the academic and all the other things that can bring us, no? So
You are totally free to speak with
exactly.
science like John Webb, Max
Uh-huh.
Ebb. Yeah, it's really
Yeah, it's amazing.
a friendly atmosphere, a
Totally.
friendly community.
Totally.
Yeah, so it is a huge opportunity both from a personal and professional point of view.
Correct.
Yeah.
Is the point.
And following up to that, do you think it is important for a spine surgeon to do also research and teaching?
The answer is super yes.
Super.
Because when you have to teach something, you have to study the topic. For this, you have the great opportunity to learn a lot. Usually, when you are in a meeting, for instance, in a course, but also in a group of research, you learn more than the others if you have to teach something.
That's
Because
true.
that's for teaching, you have to study. You cannot
Yeah.
teach something that you don't you don't know in very deep way. This is obvious, but it is the reason why when you are, for instance, in a meeting, the lecturer usually knows more than you just because he had to give a lecture. Simple. It is the same in teaching. It is the same in research. Before starting with a study, you have to evaluate what you can find in the literature. For this, you have to study.
That's definitely true. And in like talking about research, what do you think? I think you mentioned something at the beginning, but what do you think are the biggest gaps of knowledge right now in spine surgery?
Maybe this we have a lot of gaps actually. For instance, in etiology of idiopathic scoliosis, we are also, maybe the most important gap is in the mechanism, in the generative cascade. In I think this is very important because it is common. You will see patients with the degenerative changes every day. Until now, we don't know exactly what's the degenerative cascade, or basically how we can change this cascade, or we can improve, or we can prevent the degenerative cascade. This is really a complex topic. The gap is huge.
Do you think we will ever find a solution for this, or eventually, or not?
Maybe you. Maybe the next generation after you. Or generation.
Maybe.
I don't know. Because today the knowledge has a significant acceleration. Maybe you maybe. If you consider, for instance, how we treat the deformity, the scoliotic curve, basically we perform until now what Ibs did in 1911, treating the first polio scoliosis. We don't have a significant improvement in this field. Basically, we fuse after a correction. You can correct the curve, the cobangle, with the cast, for instance, or you can correct it with the instrumentation. But basically, what we do is you reduce the amount of cobangle. Eventually, you can treat also the apical rotation of the vertebra, the curve. But at the end, you fuse in correcting position. Actually, we should to try to maintain the movement. A non-fusion surgery should be the future. Actually, we are trying to treat, for instance, the scoliotic patient with the non-fusion surgery, with the this is maybe the best way in order to treat this kind of deformity, reducing the cobangle, reducing the deformity, but maintaining the
mobility,
flexibility. Yeah.
Maybe this is the future, or we have to develop more this kind of technology.
Okay. So you believe maintaining the flexibility and mobility of the spine is the future of spine surgery. Do you think there are other paths that we can follow in the future? And what do you think can be left behind instead?
But basically, it is just exactly like you are saying. Usually, we treat fusing 1 level, 2 levels, 10 levels. In every case, if you have a tumor, if you have an infection, if you have a fracture, if you have degenerative changes, deformity. Very often, in 95% of the case, we fuse.
Yeah.
Obviously, this is not physiological because the spine is not is a mobile segment.
It has to be.
This is the point. We should to try to treat this kind of different pathological condition without fusing.
Mhm.
In all, obviously we are very far. For instance, if you consider the fracture in the depth, you consider to put one or two screw inside for treating this. This is a very good surgery because you treat the fracture and at the same time you preserve the mobility.
Yeah.
But if you treat the same fracture, for instance, with the posterior approach, with the Magel or a screw, or with arms C1 or C2 instrumentation, you fuse. Obviously, it is not exactly what is the
optimal, no?
This is very important for me.
And moving to another set of questions, and coming back to your career, what is the achievement that you are most proud of in your career? If we may ask you.
Maybe I defined more than 20 years ago the unstable area in severe spondylolisthesis. I think it is very important because in this way you can know before the surgery if you have to include or not L4 in instrumented area. And this is important because if the unstable zone exclude L4, there is no reason for fusing also L4. I think it is very important, at least in my mind.
Could you, if you don't mind, tell us how you came up with the idea of the square? Like briefly, fast,
Yeah.
in a simple way. I know it's not simple, but
No. But actually, is simple because the problem that I had to evaluate at that time before publishing the paper was a case in which I reduce 100% a high dysplastic L5 spondylolisthesis. After 4 months, this young girl, she was maybe 12, something like this, she developed a severe instability in L4. And this was my first time with this kind of problem. I remember very well. I saw many times the X-ray before surgery, after the surgery, before, after. At that time, I was really interested in the paper published by in the early 80th by Vidal and Marney about this topic. I obviously combine what I had to what I learned from this paper, what I imagine the main cause of this L4 instability. I remember I spent a lot of time in looking, in seeing many times the sequence of the pre-op and the post-op 4-month follow-up of this case. At the end, I realized that we should to define the unstable area before. I try to use the knowledge coming from the Vidal Marney paper. I change something. I try to to draw a square in which you can see the unstable area. This was more or less.
Thank you so much for telling us the story behind your square. Thank you.
Yeah, thank you. Yeah, and would you consider this your most challenging case, or are there any other cases that you would like to share with us?
Actually, as you know, we perform very often revision surgery. For definition, revision surgery is a complex surgery because you have to
always
restart, you have to try to restore the alignment, or in general speaking, you have to to redo the surgery.
Yeah.
But mainly, actually, for me, it's impossible to forget a case of congenital kyphosis in a boy. He was 16 with a congenital kyphosis in T6 or T7, more or less. He had in MRI a clear sign of myelopathy. He had also under the clinical examination demonstrated that there was a problem in that way. We discussed, I remember very well, with the parents and with the patient about the surgery. At the end, we decided to do the surgery. I had a very good correction, but the patient developed paraplegia. This was for me a very bad case, more or less 25 years ago. But for me, it's impossible to forget this case.
Yeah, I can imagine.
Probably
and maybe.
Yes, please.
No, I was saying, sorry, that maybe the most difficult cases you have in front of yourself are the ones you learn most from.
The problem is when you do what you have to do without any mistake. At the end, the result is poor. This is my problem. A few weeks ago, we performed a very complex surgery in a lady with more or less 80 degrees of thoracolumbar scoliosis, more or less 50 degrees of kyphosis at the same level. I decided to perform long instrumentation, obviously from T2 to pelvis. I decided to perform a PSO in L1. At the end, I achieved a hypercorrection. Hypercorrection remains a big problem because it's not so easy to treat this. Until now, I don't know if hypercorrection is a problem or not, because I review a lot of cases with hypercorrection with a very perfect result, because hypercorrection very often give a pelvic tilt 0 or negative. This, under the mechanical point of view, is a very nice condition. But in the same time, I collect cases with hypercorrection developing severe PJK. This remains problematic. This is the reason why I do believe that you have a lot to do in your career if you want to follow this kind of surgery, because you have to understand why this happened. In some case, good result, in the other bad result. But you should to understand why this happened.
Yeah.
This is a challenge. I think it is a fantastic for.
It's a great opportunity, no?
Yeah.
To
Even
continue.
if you do your best, if you if you perform very few mistake or zero mistake, sometimes you have good results, sometimes bad results. Your role is to try to understand why this happened.
And that is the most important question always. Yeah. And just to end one of the last questions, if you could talk to your younger self, what advice would you give them?
Insist.
Insist.
Insist, yeah, because I spent a lot of time for achieving enough knowledge in surgery. That means more than 8-10 years. Obviously, during this long time, I had a lot of doubt. Is a good direction what I am or not? A posteriori, I have to say is a good was a
good direction.
This is the reason why I answer your question. Insist.
Thank you.
Good advice. Okay. So to wrap it up, let's engage in a quick game in which we ask you questions and you reply with a quick and fast answer. So your hobby?
Travel.
Yeah. And what is your favorite book?
Oh, I don't know if there is a translation in English, but anyway, Daverio was a great art writer. He wrote a fantastic book in art, including Vermeer. Vermeer maybe was most important artist that the humanity had. He wrote a very nice book about this.
What was the name, Professore?
The name of the
book?
writer is Philippe Daverio.
Philippe Daverio.
Philippe
We will look it up.
Wrote a lot of books in art. You can choose one.
Okay.
It was for me very, very, very nice, because at the end of the day, surgery is not science. It is art, because it's impossible to reproduce a surgical technique. Let me say, suppose that you publish a very good surgical technique in treating spondyloptosis, for instance. If I try to replicate this technique, maybe I achieve a very poor result, because it's correlated to my capacity to replicate what you publish. But this is not only an example. Consider, for instance, Gaines procedure in spondyloptosis. Gaines, many years ago, suggested to remove the L5 from anterior approach and from posterior approach. If you remove L5 in case of ptosis, you can reduce L4 under cranially to S1 without a significant problem, just because the L5 doesn't exist.
It's not there. Yeah.
The idea is simple, is logic. But the point was that if you try to replicate this, the risk to have a fatal bleeding is very high.
Mhm.
That means it's not like in physics or in chemistry or in which if someone publish a paper, you can replicate what the author wrote in the paper.
So
In
it's
unfortunately in surgery is not exactly the same.
yeah, sort of art, no?
Unfortunately, or likely it's depend.
So your favorite sport,
Oh,
Professor?
there is no doubt. Canoe.
Canoe.
I like to paddle.
Super.
Yeah.
Do you have a favorite surgery?
Yes, there is no doubt. PSO.
Yeah, so we guess so, Manto and I,
Okay, yeah.
when we were preparing the interview. Freehand or navigation?
Oh,
We also know the answer probably, but
can we jump this question?
yeah.
Okay, so open or minimally invasive surgery?
Oh, more or less the same.
More or
Okay.
less the same.
Jump what? Okay. Thank you.
And if you had to define a spine surgery in one word, what would this be?
Hmm. Hmm. Maybe an explorer.
Unexplored.
No, an explorer.
An explorer.
Yeah, somebody that is exploring
Uh-huh.
the future. Something that is. I think the right word is explorer.
Explorer. I like it. We have
Yeah.
never guessed
It's a
this,
very
right,
positive
Manto?
definition. Yeah, I
Yeah.
love it.
So thank you so much, Professor, for joining us today. I enjoy it a lot, and for telling us your stories and your personal career, and for being part of our new community, the Spine Youth Club. Thank you so much, really.
It was really my
Thank
pleasure.
Thank
My
you.
pleasure. My pleasure.
our pleasure and our honor. And to all our members, stay tuned for the next interview.
Yes.
Thank you.
Thank
Thank you. Bye bye.
you.
Thank you.
Thank you so much.
Thank you so much.
Bye.
Stop recording.